Welcome back to the Curbsiders. I'm Dr. Matthew Watto, here with America's primary care physician, Dr. Paul Nelson Williams. Paul, ready to talk about bipolar disorder?
Oh, no, I'm no longer a great friend. I've been demoted. Yeah, I'm ready, Matt. How are you?
You're still you're always a great friend, Paul.
Uh-huh.
So we had a fantastic discussion with Dr. Kevin Johns about bipolar disorder. And Paul, I just wanted to ask, is this an easy diagnosis to make? Is the diagnosis delayed by years? Can you make it at one visit? Tell me a little bit about that and what questions might be asked to uncover this diagnosis.
Yeah, listening back to the episode in preparation for this, it just came up over and over again. This is a hard diagnosis to make. And Dr. Johns even made the point that he may talk to patients on his first visit and be like, yeah, I'm leaning towards this. I don't know for sure. It's going to take us time to get to know each other before I can make this diagnosis. So it takes time. It often takes collateral information, or at least collateral information is helpful. And I think a lot of patients misunderstand sort of what bipolar disorder is specifically. And so the way he asks about it, there has to be a sustained period where they've been behaving differently. So typically this can actually manifest as depression the first time through, but he will ask patients just to make sure there's no history of mania. Has there ever been a week where you've had increased energy, or maybe people thought that you're behaving differently, or you're even more irritable? And the last thing, a week is important. The irritability is important too, because I think our conception of bipolar disorder, the manic phase being just all high energy and positive and happy, and actually can manifest as sort of irritability. So it's hard to get collateral information sometimes for these patients. So asking them, were you perceived differently by somebody else, or did someone tell you that you're asking differently, can sometimes be helpful in making the diagnosis as well.
Yeah, he was saying that, patients, they can be happy and sad and, feeling euphoric and crying like all at the same time. And you can understand how it would be when you're starting treatment for this, you might have incomplete information, especially as a primary care if you're meeting someone for the first time. I always worry about when I'm starting medication for depression, especially in younger folks. Am I going to accidentally start them on a medication that might worsen things? So I want to talk about, Paul, let's say we do know someone has the diagnosis. He mentioned, just to quickly mention it, there's a CIDI bipolar screening scale that you can use. And it's like a script that goes through these 3 questions, and, that can help you make the diagnosis of bipolar. But let's say we've diagnosed somebody. Some of the counseling he talked about was, tell the patients and their family members that you really want them to live as healthy a lifestyle as possible. No sleep deprivation, so making sure they're getting restful sleep, exercise, they're eating a healthy diet. All these things can help promote mental health as well. And then talking to the family members about looking out for early signs like changes in their behavior, increased irritability, those kind of things, because then you need to bring them in right away so that they can have their meds adjusted or just check in, see what's going on. But what medications, Paul, can people think about for bipolar disorder? Because and how might you tackle this?
Yeah, it's funny you mentioned sort of the therapeutic lifestyle stuff, which is important because a lot of these medications can actually contribute towards metabolic syndrome, which is important to know. But in terms of what maybe we might be comfortable starting in the primary care setting, it's sort of undifferentiated and you're not sure, but you want to start something. Quetiapine is one that I think that we talked about a fair amount, which I think we've all had some comfort with or some exposure to. Lorazepam is another one that I think we all would feel reasonably comfortable prescribing. And then there's some other medications that we might be a little bit more nervous about just because of the side effect profile and the therapeutic window, like lamotrigine might be one, and lithium might be another one. And I guess I'm going to ask you a question for a change, Matt. I mean, these are all things that we're worried about, sort of just making sure the patient does have mania. Are these things all going to treat depression the same, or are we covered kind of no matter what?
Right. Yeah. So the list you just gave, lorazepam and quetiapine, those are both medications that could treat the acute phase of a bipolar depression. Lamotrigine can treat bipolar depression, but because you have to start it slowly and titrate up because of the risk for Stevens-Johnson, it's not really a great choice in the acute phase of depression. All the atypical antipsychotics, they can work to treat acute mania, but not all of them work for bipolar depression. So that's why we're mentioning, because depression is the most common phase, is the most common. They're going to have more depressions than they are manias. So that's why we're talking about lorazepam, quetiapine, as medications that could potentially treat those. And lithium is just, for primary care, there's so many drug-drug interactions and real long-term risks with the kidneys and diabetes insipidus, and things like that, it's probably best that a psychiatrist is helping to manage that unless you have the kind of training and feel really comfortable with it for some reason.
That was probably the most conceptually eye-opening thing for me, Matt, was just the idea that the depression of bipolar disorder is managed differently than depression of major depressive disorder. Like it is fundamentally not responsive to the same treatments they would use for major depression, which just is not anything that I thought about before.
Yeah. See, because I had heard, maybe it was a pearl that I dusted off that, okay, if you prescribe SSRIs or SNRIs for bipolar disorder with depression, that it could precipitate mania, or it could cause rapid cycling of, depression and mania. But I didn't realize that it was also that they're just different, like the kind of depression they have, whatever's going on and is just different, and it does not respond to the same medication. So even you could be delaying just effective treatment by giving them an SSRI, even if they don't have rapid cycling or precipitate mania. You could still cause harm by just not giving them most effective treatment. So yeah, this was great, Paul. I mean, there was so much on this episode. More than we can cover in this short video. So be sure to click on the link in the description below if you want to hear the full episode, which I would highly recommend. And with that, until next time, I've been Dr. Matthew Frank Watto, and this has been another episode of the Curbsiders, bringing you a little knowledge food for your brain hole.
It's a new year. I'll say yummy every so often. Why not? What am I holding on to, Watto?
Okay, do you want to sign off?
It's completely thrown.
Okay, so I guess good night.